Hello, I'm Martha Kingman, and I'm a nurse practitioner that has worked in pulmonary hypertension for 24 years at UT Southwestern Medical Center in Dallas, and I retired last year. And I'm here today to talk to you about how to screen patients with ILD for the development of pulmonary hypertension. There are some general screening measures that we'll talk about, and then we'll talk about the specific screening tool of echocardiogram. So first, just to touch on the general screening. The first one is taking a good history every time the patient is seen in the ILD clinic and asking about their level of shortness of breath and fatigue. And what you will see if the patients are developing pulmonary hypertension is that they're much more short of breath, they're much more fatigued, but their pulmonary function tests and their chest imaging are stable. So that's just one little clue. The other clue clinically can be on physical exam. And if you are noticing on exam that the patients have an accentuated second heart sound, we call a loud P2. That can be a clue for pulmonary hypertension. And certainly if they've developed right heart failure and you're noticing lower extremity edema or JDD, those should be getting your attention as clues that the patient may be developing pulmonary hypertension or may already have. The 6-minute walk test is done routinely screening ILD patients. And there's also some clues on 6-minute walk tests that you can pick up on if a patient has developed pulmonary hypertension. First, their walk distance will be declining, usually to less than 350 meters, and they will desaturate more quickly and more severely. So their oxygen needs will go up on 6-minute walk test. And if you see that again with stable pulmonary function testing and stable imaging, that should be a clue for you that the patient may be developing pulmonary hypertension and something to think about. Additionally, on pulmonary function tests, there's clues that patients may develop or may have pulmonary hypertension. And one is that the DLCO will be declining. And if you see a DLCO that's decreased by more than 15% or to an absolute value less than 40% of predicted, those are signs of pulmonary hypertension. Or if the forced vital capacity over DLCO ratio is greater than 1.6. In other words, the DLCO is disproportionately low to the forced vital capacity. All of those are mild clues that the patient may be developing or may have developed pulmonary hypertension. Routine chest imaging is sometimes done. If the patients are telling you they're more short of breath, you might get an HRCT. And on the HRCT, you may see stable interstitial lung disease, but enlarged right ventricle. So it's another thing that you can look at. Also, the pulmonary artery can be enlarged on CT imaging. Lastly, the biomarkers generally aren't routinely done in interstitial lung disease monitoring. However, if you do them, and the BNP and the NT and NT-proBNP are elevated, then that could support your suspicion that the patient may have pulmonary hypertension. So once you've raised your suspicion for pulmonary hypertension, then an echocardiogram should be ordered and performed. On echocardiogram, what you will be looking for is an estimated elevated RVSP, right ventricular systolic pressure being high, with the caveat that those pressure estimates are often inaccurate. What is really important to look at is the right ventricle and the right atrium. If you have right atrial or right ventricular enlargement and or right ventricular dysfunction, those are big clues for pulmonary hypertension, and that patient needs to have a right heart catheterization. So from there, you would refer them to hopefully a pulmonary hypertension center of excellence, where someone that is qualified and experienced in performing right heart caths can do that to see if they may have it, and if so, are they a candidate for treatment? So in summary, there's a lot of just general screening that goes on with ILD that can give you clues to the development of pulmonary hypertension. So watch for disproportionate dyspnea, a declining 6-minute walk distance, increasing oxygen needs, decreasing DLCO. And then if those things are present, get an echocardiogram so that you can intervene early and get that right heart catheterization done. So thank you very much for attending this, and I appreciate your attention. Thank you.